Hello, I'm Jan Tack. I'm going to present an introduction on gastric motility disorders. I'm a gastroenterologist at University Hospitals in Leuven, Belgium. So the stomach is a complex organ. It has many functions: initial storage of the meal, then it starts digestion, releases it to the duodenum in a controlled way. It helps to defend against GI infections. It's involved in satiety and hunger signaling, and it helps absorption of vitamin D. And if we look at the physiology centered around meal ingestion, prior to the meal, the stomach is actually contracted, and during the meal, it relaxes to store the meal. We call this accommodation, and then the next phase is emptying. Throughout meal intake and after the meal, there's a sensation, a perception, which should be favorable, positive. And also meal intake triggers gastric acid secretion and release of certain peptide hormones. And when the meal moves into the duodenum, gastric acid secretion alters, there's duodenal secretion, and different hormones are released. So all of this is complex and can go wrong to give rise to gastric symptoms and to a number of conditions. In the Rome 4 consensus, these are the main conditions associated with gastroduodenal functional disorders. And I will be mainly addressing functional dyspepsia. I will be addressing nausea, vomiting, and gastroparesis. So functional dyspepsia, this is a just published European consensus, is a condition characterized by postprandial fullness, early satiation, epigastric pain, and burning with a negative endoscopy. Often associated upper abdominal bloating, nausea, belching, and gastroparesis, also from the same European consensus, is a condition characterized by symptoms associated with delayed gastric emptying in the absence of mechanical obstructions, and the symptoms are nausea, vomiting, and early satiation and postprandial fullness. So let's go in a little bit deeper into the symptoms. Where are stomach or gastroduodenal symptoms felt? In this square, actually, between the umbilicus, the lower end of the sternum, and the mid-clavicular lines. And the symptoms that can be experienced are depicted here in pictograms: fullness after meals, early satiation, a tightening so the stomach doesn't open to store the meal, epigastric pain and epigastric burning, and there's often also upper abdominal bloating, a sense of gaseous distension. Heartburn is behind the chest bone. Nausea is a kind of sinking feeling in the stomach, and belching, I think, is self-evident. So when patients present with these symptoms, we will usually do an endoscopy, and when that's negative, it's considered to be a functional or motility disorders, and then we can do additional tests. Why should we consider doing additional tests? Well, they may help to explain the symptoms, help to make specific diagnosis, determine the choice of treatment, and predict long-term outcome. Any test that does all four of these is a very useful, almost ideal test. I will be showing you some data on patient cohorts seen with upper GI symptoms and negative endoscopy. The prevalence of symptoms is shown as the yellow bars, expressing percentage of the population of patients who have them in a moderate to severe fashion. And the patient populations I will be addressing are overlapping dyspepsia and gastroparesis, two different groups who have some overlap. So the first test we can do is measure gastric emptying rate. And there's many techniques, but clinically it's scintigraphy, breath tests, and smart pill that are the relevant ones, the ones that clinicians use. The oldest one and best established one is a scintigraphy. A meal is radio-labeled, it is ingested, and when the patient has ingested the meal and is behind a gamma camera, you can see the outline of the stomach with the radio-labeled meal in there. You draw a region of interest, and you look over time how the radioactivity disappears from the region of interest, and that allows you to calculate gastric emptying time. In the US, there is recommendations on how to do the test, which meal to use, but still I think there's a lot of heterogeneity, and in other parts of the world, this recommended uniform test has not been picked up. In Europe, and actually in our center, the breath test was developed, which uses a stable isotope labeled meal component. 13C is non-radioactive, and that substrate is degraded immediately when it empties from the stomach. It's degraded in the duodenum, digested in the liver, and appears in the breath as 13 CO2, and you have an appearance and disappearance curve or a cumulative filling curve. And from these curves, you can actually use different mathematical models to link them to scintigraphy, and so it allows you to get the same type of information as you would get with scintigraphy. Very popular in the US, a little bit less in use in the rest of the world, is the smart pill, which measures pH, manometry, and temperature, and allows to quantify gastric emptying time, intestinal transit, colonic transit, and phasic motility on one manometry port. This is an example of a tracing. You see the drop in pH when the capsule falls into the stomach. You see phasic contractions here, and when it leaves the stomach, you have a higher pH. And further down the tracing, you can also identify a transition point between ileum and colon. And when the temperature suddenly changes from 37 degrees to surrounding temperature, it means the smart pill has left the body. That allows to measure colonic transit time. Actually, the driver of emptying are high amplitude gastric contractions, either phase 3 or isolated big contractions. And so if you look at the correlation between the smart pill determined gastric residence time, seen as a pH step up, or the phase 3 of the MMC after the meal, this is well correlated. So it doesn't measure emptying directly, it measures an indirect phenomenon, the permission again of gastric phase 3 after the stomach has emptied completely. And can you explain symptoms with it? Well, first of all, if you look at 100 patients, around 30% of them with upper GI symptoms and negative endoscopy will have delayed gastric emptying. And in our hands, in yellow, compared to those with normal emptying in white, they have more fullness, more nausea, and more vomiting. And a couple of series in the literature, especially when patient groups of more than 300 were studied, found similar correlations, mainly with fullness, nausea, and vomiting. So there is a link with the symptom pattern. This is also often used in diabetes, and in diabetics, there's also a correlation between the retention of solids at 100 minutes on scintigraphy and the symptom score. It is a significant, not very strong correlation, but again, if you look at the symptom pattern, 2 of the studies actually show an association with bloating fullness, but the sample size is smaller in diabetics. And then does it determine treatment? Well, the idea is that delayed gastric emptying through several pathophysiological changes induces gastroparesis symptoms, and that prokinetic drug treatment can reverse that, and that will be addressed in the treatment section of gastric motility disorders. The second one, which I will address shorter, is the gastric electrical rhythm. Contractions in the stomach rise from around this zone and travel down towards the pylorus to empty gastric content. And we now know that these are driven by interstitial cells of Cajal, a special rhythm-generating cell network and a pacemaker region here. But now there's a new evolution with a body surface gastric mapping device developed in New Zealand by Greg O'Grady and colleagues, which allows to map in detail the origin and propagation of slow waves. And I think this idea of measuring the rhythm-generating symptom is again up for a renewal and a revival. Gastric sensitivity is another one. You know, after the meal, there is perception which should be pleasant, and also during the emptying phase, there is perception, and we can study this by blowing up a balloon in the stomach and looking at the threshold to induce discomfort or pain. And compared to control or organic causes of dyspepsia, let's say a peptic ulcer, patients with functional dyspepsia, so with negative endoscopy, are abnormally sensitive. Here in this study, more than 60% were abnormally sensitive. If we put all the studies together, it's 40% that are abnormally sensitive to gastric distension. And in our hands, in yellow, hypersensitivity to gastric distension compared to the normal sensitivity in white is associated with much more pain, much more belching, and unexplained weight loss. So we call this visceral hypersensitivity. It's a modality that is not measured in clinical practice, but it is a driver of symptom severity in many conditions, including FD, including gastroparesis, and in the lower GI tract as well, in IBS, for instance. The last factor is gastric accommodation. This is the first phase of meal ingestion. You ingest a meal, the stomach makes space for it. And we already have indirect evidence that this is abnormal in functional dyspepsia. In health, the radio-labeled scintigraphy meal is immediately after ingestion, mainly in the proximal stomach, whereas in FD, with normal emptying here, it is in the distal stomach, suggesting that this part does not relax well. The gold standard is the barostat, a balloon device swallowed, lodged into the proximal stomach, inflated with a fixed pressure that allows to measure volume shifts in the proximal stomach. This is the preprandial. After a small liquid nutrient meal, this is a postprandial proximal stomach volume, and you can quantify this. And if you do this type of measurement or alternatives, imaging, for instance, like scintigraphy or with SPECT imaging, you actually find that 44% of patients with upper GI symptoms and negative endoscopy have abnormal accommodation. And in our hands, this is associated in yellow with early satiation and unexplained weight loss. So also this one is associated with the symptom pattern and is present in a subset of the patients. Now, the barostat balloon is invasive. It's a big thing to swallow. It is unpleasant. Nobody uses it in clinical practice. So people have looked for alternatives for the barostat measured accommodation. A simple one is the nutrient drinking test. A liquid nutrient composition drink is dripped into 2 beakers. The patient is asked to drink and keep up drinking by alternating the beakers as they fill and scoring satiation every 5 minutes. And if you do that on one day and you look at the end point, the calories or volume ingested when they stop, this is well correlated to a barostat test on another day. So this is a very simple gastric accommodation testing procedure that you can do in patients. The other one has been manometry. This is a standard esophageal manometry catheter now moved into the stomach. And if you move into the stomach, this is what you get. This is the lower esophageal sphincter with swallows. The single line is a single swallow, esophageal peristalsis. This is the proximal stomach. This is the antrum, phasic contractions close to the pylorus. And here ingestion of a liquid meal is started, and soon after, the pressure in the proximal stomach drops. It becomes blue, lower pressure, because blue is low pressure, green intermediate, red high. So you get a low pressure that gradually recovers. Upon meal ingestion also, the phasic contractions in the antrum are suppressed. And so if you plot this, you get a drop in intragastric pressure, followed by a gradual recovery, and this is associated with the rise in satiation score. And if you do this in controls in blue versus functional dyspepsia patients, the drop in pressure is suppressed in functional dyspepsia. The meal volume tolerance is smaller in functional dyspepsia. The rise in satiation with meal ingestion is faster in functional dyspepsia. And the size of the pressure drop is correlated to the tolerated meal volume, so showing that this pressure drop is an indirect measure of gastric accommodation. So how does this work in clinical practice? People are seen with symptoms, fullness, satiation, pain, burning. This is the dyspeptic symptom pattern, or nausea, vomiting. You do the endoscopy, and it is negative to think of a motility disorder. Here you do the endoscopy, perhaps some other investigations as well for nausea, vomiting. If the endoscopy is negative, here you have a functional dyspepsia diagnosis. Here, with negative findings, you have chronic nausea and vomiting disorder. And then if you do the emptying test, it can be normal or delayed. In dyspepsia, if it's normal or delayed, you have dyspepsia with normal or delayed emptying. In nausea, vomiting dominated people, you have, when it's delayed, gastroparesis, when it's normal, chronic nausea and vomiting disorder with normal emptying. So that's what I wanted to tell about gastric symptoms and gastric testing, and I hope you enjoyed this brief presentation. Thank you for your attention.